It could be kind of long talk, but I put both together, so I will switch from the spine to the posterior fossa and spina bifida, and then to some aspects of the dilated posterior fossa in early gestation. So good morning, everybody. Thank you, Gustavo, for this brilliant talk, convincing that the best time to control the first trimester brain is at 15, 16 weeks, and this is actually what we are doing. But I will speak first on the spine, and let's go back to the ultrasound anatomy. We can start at the embryologic stage. This is at 9 weeks, where you can, if you need, check the spine by this way. At this stage, you can touch the uterus, you can change everything, but you will never succeed to get the fetus in different positions. So if you want really to study the early embryo, there is only one way: skill, do a lot of things, but you have to learn very good to do a 3D ultrasound. So this is here some embryos from 16 millimeters to 36 millimeters. You can see the shape of the body, and this can be of importance in some high-risk patients, but in general, rarely an expert will scan first patient at this stage. But if you are doing some dating and some other things, this is nice. And let's say I'm confident that in some years, 5, 10 years, we'll be doing this routinely as we're doing nuchal and first trimester scan. So in some selective conditions, you can see the fetus transvaginally this way, and the parents recognize that the spine looks normal. But I always tell them, I'm not sure, it looks nice, but at this stage we cannot guarantee, because there are some defects. They can appear later on, even if let's say, I have a good feeling when I see this, and I can do it also transabdominally by using a linear probe, as we told you yesterday. And you can see here the conus medullaris, and as was said yesterday, it goes until the sacral part. So this is also a good approach if you don't want to do it transvaginally. So go for a linear probe. This is a good way. And if you are looking to the spine, you can also have a look to the baby from when it shows you the back. So this is a good view on 3D, either transabdominal or transvaginal. But in general, if you are checking the spine and the brain, we should go for the mid-sagittal view and the axial view of the head. So in this plane, you can see the nasal bone and the nuchal, but you can see also some parts of the brain I will discuss later on in my talk. And you can see also in axial plane the butterfly sign with the septum, with the falx cerebri dividing both halves of the brain. The same can be got by higher resolution. And you see here transvaginally, but you see here that once you go transvaginally, you see clearly then the cortex here, you see the plexus, and you see here the transition between the third ventricle and the other part. So, and a mid-sagittal view is extremely rarely possible to get this exact mid-sagittal plane. So I recommend you, if you want to examine very good, a good friend of yours, do transabdominally the nuchal, the nasal bone, and these things where you are obliged to get the mid-sagittal view. And then you can continue quietly transvaginal, because then you can change slightly the position of the baby, but you cannot oblige the fetus to show you the nasal bone. Sometimes you see only the abdomen, and the nasal bone is not got very well. So this is an approach. And if you are using transvaginal scan for early gestation, in my opinion, you should learn 3D, because you acquire rapidly a volume of the head, and you can render. You can use such a line like one cut, and you have the mid-sagittal view. You see the posterior fossa with the intracranial translucency. You see the brainstem, and you can get a tomographic view or multi-slice view where you see the different parts of the brain, from the falx into the third ventricle. You see here the cerebral peduncles. You see the aqueduct of Sylvius, and you see here this upper part is cerebellum, and this is the fourth ventricle. This echogenic line is the plexus correct of the fourth ventricle, and so on. So this is really very nice, and this is something I don't do after work, I do during the scan. I acquire a volume because the baby is not in good position, and then I do this, and I measure occasionally here the IT, or I rotate. And if I want to measure the brainstem to the distance, I can do it this way. So I encourage you to do it. If you know how to manipulate the volume, you can easily access on every fetus. I assumed in the past that by using some special mode like maximal mode will allow us to see the spine at at 13 weeks, like at 21 weeks. But this is a really rare good image because the ossification is not so, let's say, impressive that it can give you images. And sometimes you can use such an approach like this is silhouette, or you have seen in the White Journal an article on crystal view showing the same approach to the spine. So these are new features. We don't know yet their value, but another way also to see the bones. Let's go first for the abnormal spine. Well, in general, if you go for different spina bifida, today the accepted classification is the one published by Tortori Donati in his large book of neuroradiology. But let's say more or less what we need to know is the first group is the open spinal dystrophism with melemeningocele and myeloschisis. Then the closed spinal dystrophism with lipo and meningocele, one group. But you see here we have a lot of things, but I think for early gestation, these could be also very, very important. The caudal agenesis. Caudal means lower than the spine, not only the sacrum, but it could be the distal part of the spine, and some rare diseases called segmental spinal genesis, where some parts of the vertebral bodies are missing. So let's go for the first group, and this is something many of you have seen, because this can be isolated or can be part of other abnormalities, caudal regression or caudal agenesis or sacral agenesis. I will mix up some of these, but more or less, we have one group where only the os sacrum is missing, and this is very difficult to detect either in isolated or in combination. But when you have patients having diabetes and you are looking for caudal regression, this is something you look for, but let's say in isolated cases are difficult to see. The agenesis of the caudal part of the spine, this is something very impressive, and I'm sure every one of you will see it, even if it's isolated. The body stalk anomaly we discussed yesterday, and Katya covered a large part of it, also called limb body wall complex. And one group similar to the body stalk anomaly, but with the normal umbilical cord, is the OEIS complex for omphalocele, extrophy of the bladder, imperforate anus, and spinal anomaly. This is a severe malformation complex. Last but not least, we can have segmental spinal dysgenesis, and one of these groups is also considered the ceromelia. I will not discuss this issue today because this is, when you look at the legs, you will see them easily. So let's go for the first group, the caudal or sacral agenesis in association with abdominal wall defect. In general, the first hint is the large omphalocele. And then the next step is you see more than one omphalocele. You see something more, the legs are abnormal, or you see more parts outside of the body. And this can be one of these. In general, this one is the body stalk anomaly is very stuck to the placenta, and sometimes if you look carefully, especially in early gestation, you see that some limbs or some, especially the liver, is outside of the amniotic cavity. And the other group is with no omphalocele, but the distal part of the spine is absent, and the pelvic bones may be present or absent. The legs are very abnormal. You have sometimes one leg missing, or the position of the leg is abnormal, and we'll see this later on in our talk. So this is from a new paper. It's going to be published this year in Fetal Diagnosis and Therapy from Panatescu and Fred Ushakov and co-workers. And this is the two groups I will discuss. So you see one is stuck to the placenta, and the other one has a normal umbilical cord, but let's say the body here, the lower part of the body from omphalocele to the posterior part are missing. And the typical hint of these are that the fetus is stuck to the placenta. So occasionally you may see that part of the fetus is outside the amniotic cavity. There is no mid-sagittal view of the complete fetus because, especially in this one, you don't have, let's say, with one axis the fetus can be seen. And if you look at the spine, it shows very often deviation. Not all of these are, let's say, they have some spinal anomaly in, let's say, in the term of absent part of the spine, but in general you have some severe deviation. And very often you may see in severe forms the feet present behind the fetal body. In two cases, I had a referral of this condition by some doctors telling me, I suspect some abnormal twins. And the idea is that they saw the head, but they saw behind the head a foot. And they say, why, how can a foot be behind the head? It's not possible. They assume there should be another fetus they cannot see. So if you have, let's say, one phone call, oh, I see two fetuses, one the feet and so on, think about that it could be this condition, which is so typical, or some part of the body beside the head. So I show you, this is a case I saw last year. In June, as you see here, the doctor sent the patient because he assumed that the CRL is short and he saw a megacystis, which is already more than enough. But you see here what this fetus has is at the lower part of the thorax, this is the heart, the spine is stopped, and this is here something between liver and could be a bladder or anything else. So, and you see here, this is 12 weeks plus 6, you see the spine, and you see the heart here. And you look at here, some parts of the placenta are outside of the liver, are outside of the cavity. There is no umbilical cord you can see. I put the head to show you that the posterior fossa was normal. And you see in this plane, the head is near what could be the bladder or something else. So it is a body stalk with half of the body absent, no legs present. Yeah. And this is here, the image, you see here the amniotic cavity and this extra embryonic coelom, and you see the body here on 3D. It was difficult to get it because of this position. So the lady asked me, how early do you think we can rule out this condition? I don't know, but a friend of mine in France, he told me that around 8 to 9 weeks, we may see something abnormal at this stage. So she called me back 2 weeks later, 1st of March. She's now having twins, and it's at 8 weeks plus 1 day. And this is what I could show her. I said, look at the spine. And this here is the cavity. This is on 3D. You see the embryo at stage 21. You see the arm, the legs, the tail even at this stage. And this special rendering where I augmented the threshold to show her that the whole fetus is within the embryonic cavity and the umbilical cord with the ductus omphalocentericus until the yolk sac can be seen. So in selective cases, it's reassuring. She will come back at 10 weeks and then later on for the nuchal resources. So in some selective conditions, it's worth to tell the parents that some things can be ruled out. But of course, it's so rare, you will not start on any patient to look at this condition so early. This is another case of Botistock anomaly. You see here that the spine has an abnormal shape. You see the large omphalocele, and you see the spine has this scoliosis in comparison to the normal condition. This is something you can make a projection of because this angle is never in one plane. You can see it on a projection, but it's not in one plane. So you cannot get a view of all this on a time if you don't use 3D. The other group which is interesting and challenging is the caudal or sacral angiogenesis. Caudal means from thoracal, lumbar, or lower, but they don't have typically omphalocele or body stalk. So this distal part of the spine is absent, and as I told you before, the legs are a typical hint for this, and this is why for me the two main hints you look for in these conditions is first you have a short crown rump length in comparison to gestational age, but you have a normal value for abdominal circumference more or less and for BPD. That means you think the baby has a normal size, but you see it looks short. It looks so short that the head appears large in comparison to the body, similar sometimes to some triploidy cases where you see a very tiny thorax, but you don't see the complete fetus. And if you look at the legs are almost always in abnormal position. So, and then if you are trying your best, you will see that the spine is interrupted at some stage. So, show you this image. This is here 14 weeks plus 1. More or less, we should expect 85 millimeters, but we have 72. And you see here, this is the head, and the whole body is as large as the head. You see the spine is stopping at this stage. This is some part of the pelvic bone. And you see here, this image shows you what I was trying to explain you. This is the spine and abruptly stopping at this stage. And you see the pelvic bone is seen here. You see the legs are abnormal, but I show you better images of this condition. So again, the same now. This is 14 plus 1 oblique view or sagittal view. You see here, a coronal view, I mean. You see here that the spine, the ribs, and it stops at this stage. You see two kidneys. And you see this is my peripheral linear probe, and you see it stops at this stage, you don't see anything, and then So this is one case. And I told you, this is what I found on internet, the so-called Buddha leg position. And this is a view from below where you see the two legs and you see the feet are touching each other like when doing the applause. You see here, there's a typical Buddha position of the legs in these because in this disease because we have also fused pelvic bones. This is another case. You see here the spine stopped here, and you see here interruption. Now this other case is 13+6 transvaginally, and again similar view, but the legs are severe abnormal. You don't see a complete leg. You see some foot stuck here, but you see the spine is interrupted at this stage, the pelvic bones, and some rudimentary feet. And this is here the example 3D stopped here with a kinking stopped, and you see some foot, and you don't know what is what because this is no typical legs and feet. So, and the last case I want to show you is this one. This was a kind of challenge because the spine was present until the, let's say, the sacral part, but the typical finding was the legs. The legs were really severely abnormal. You have half a leg like this. And she decided to continue pregnancy, and I was wondering how the baby looked like, but 2 weeks later the baby had died. So, but you see here, the legs were the main hint, plus the short CRL, and you don't have this stretched part. And the lower part of the spine is rather curved anteriorly than posteriorly, how we see it under normal conditions. Two findings which are really very, very difficult to detect. The hemivertebra, if you look at, if it's so severe like this, you may see it, but in general, we will miss all these hemivertebra in early gestation. And there are findings like this one. I don't really know how to classify it. You see here, this was a fetus with the Grouchy syndrome. We heard yesterday that this is one of the anomalies associated with brain defects. And you see here this interruption. It can be diastomatomelia, but it can be also segmental spinal dysgenesis, that some part of the spine are missing. And you know, like me, that in early gestation, the, let's say, post-mortem examination is really very bad nowadays because we don't have a lot of people doing good pathology anymore. It's not well paid compared to cancer. The second part is done on open spina bifida. Ideally, you know, my ideal theory of yesterday, every patient got a scan until we see that there is a spina bifida, but if you look at the data, it's not that way. So this is a typical myelomeningocele, obviously seen. This is 4 millimeter, rather tiny, and this here is only seen if you are really looking for the myeloschisis. This is something, not even in second trimester, you will see it primarily. You know the brain changes, and then you go there. The reality is, and this is one of the studies, but I could show you other studies, and you have seen yesterday the study of Singelaki where she showed that 5% were detected in large series, that almost all open spina bifida are ruled out, are not detected or overlooked in early gestation. So, yes.
20 years ago.
Yes, but you know, still. Let's say, ask in the audience, before the era of IT, who missed spina?
In this paper you show they missed all the cases of anencephaly.
No.
Yes.
No.
Yes.
No. Not Kypros group. Not Kypros group. No.
But it's something different because this.
Look, the issue is, let's say, when I started working on this, it was a feeling, because when you discuss with patient, interestingly, there are two diseases very often asked by patients. They ask about Down syndrome and they ask about spina bifida. Down syndrome, they ask because of maternal age. You know, the mother told her daughter, please hurry in having to marry because you are still young, you can have children, and you don't have the diseases of the older woman. And the second is the doctor say, this is folic acid, take it because otherwise the baby may have spina. So you see the lady at 11, 12 weeks, and she asks you, what is the risk of having Down syndrome? You say, you know, these numbers, no, it's 1 out of 1,550, and don't worry. And have you seen spina bifida? I said, okay, no, I cannot tell you. And let's say it changed my behavior because at 22 weeks, I was telling them, I'm sure to 99.9% there is no spina bifida because there is no lemon banana and so on and so on. But you know, for Down syndrome, well, we can rule out 60, 70%, but we can have soft markers. in the early gestation, I felt more comfortable for trisomy 21, but spina bifida was absent. And if you look at the papers, and if you look at retrospectively cases, they have no banana, no lemon sign, and so on. This is why we're looking for additional signs. And this is why I'm happy that, let's say, the uptake was good. So ideally, we may see this, but this is not the simple way of screening. If you have one condition out of 1,000, I prefer to train people to check the heart, because this is something which is more common. But anyway, so in this case, believe me, some years ago, I would not have automatically say, oh, here I suspect a very small spinal bifida, only because I show you the image. But if I put 20 images, you will find more or less in some that there is something abnormal. So if you are working and worried about one condition, you will try to see it all the time. So it should be something very simple. So the simplicity was that, this is another case here, and this is a court, okay? Something will say, oh yes, spina, and then you add color and support. So it's not as obvious as we show you, and believe me, the speakers, they don't show you all their cases, they show you the best cases they have. So you see here the fetus transvaginally, you don't see it, you wait until it jumps, and you see the 4 millimeter myelomeningocele. So what I liked in this approach is that I received in the meantime many emails telling me, oh, Dr. Chawbi, thank you very much. We had recently detected a case where we haven't seen it first, but the posterior brain showed us, and so on and so on. So I think it's a good sign. And you see here, this is now when you wait until the fetus turn, you will see, because I know what I want to show and I see it. Anyway, this is here some 3D. This is at 13 weeks. This is the case we saw last year at 11 plus 5 weeks. And this is the case you saw before with the myelomeningocele at 12 weeks with 3D rendering. This was a case as the one I told you at 14 weeks, because second opinion. The colleague scanned at 12 or 13 weeks, said, I see an abnormal posterior fossa, but I don't see spina bifida. Should I wait until 15 weeks, 16 weeks to have AFP and the changes, or send the patient, we can check? And we saw this here, this interruption, because the brain was abnormal. But interestingly, at 14 weeks, you see already the banana sign. This is why the concept was, if we have second trimester intracranial changes starting from 15 weeks. It does not start in the night between 14 plus 6 and 15. It starts already in early gestation. So we need other signs to check for the spina bifida. And the whole first trimester scan, my main message for you is, do not automatically try to apply your second trimester to first semester. It will not work. We all of us need some very new approaches, original one, intellectual one, from point of view of embryology, to understand what's going on. Yesterday, John Hyatt said that they have normal liquor fetuses with bilateral agenesis. It's true. You don't have the sign of absent amniotic fluid for Potter syndrome, but you may have the sign of persisting of non-visualizing of the bladder, and then you will check, either you wait until you see the kidneys, or you wait 2 weeks until you see the anhydrous amnio. So this is also an approach, but if you see the full bladder and you see at least one kidney, you are almost sure it is rather not the typical renal agenesis. So the brain, what happens in the brain in early gestation? It happens what is anyway happening embryologically, that the open spina bifida leads to some changes in the brain stem in the posterior fossa, leading to this small posterior fossa we know. And the anatomy of the posterior fossa has to be understood. So what we did in this approach is, let's say, the original approach is similar to what Kypros was doing in the 80s. In 86, Kypros took the Chiari-2 malformation, which is the descending of the development cerebellum into the posterior fossa, and he translated this mid-sagittal approach into an axial approach, because he was saying everyone is getting a BPD measurement in the 80s, because the BPD measurement is important to know gestational age and is important to rule out anencephaly. So in this plane, everyone is doing. We can look at the cerebellum and we can detect spina bifida. So what we did here is we said there is anyway some kind of changes in the posterior brain. Take a plane everyone is doing. Which is the plane everyone is doing? Not transvaginally the posterior fossa, because this is a targeted issue. The plane everyone is doing is the mid-sagittal plane looking to the nasal bone and to the nuclear translucency. While you are walking from here to here or backward, you can look at what's going on here, and you see that we have a brainstem, we have, this is the sphenoid bone. What you have is a thalamus, the midbrain, the mesencephalon, the brainstem, and the myelencephalon. But you see here that between the brainstem and the occipital bone, we have some fluid. This fluid is not only the fourth ventricle, it's the connection between the fourth ventricle, the future fourth ventricle, and the future cisterna magna, both separated by this choroid plexus of the fourth ventricle, which is very important anyway in the whole posterior fossa evaluation. We'll see it later on. So because the vermis has not yet developed and could not cut between the fourth ventricle and the future cisterna magna, this is one package of fluid, and this is what we can see clearly. Later on, you can say, yes, we have 3 different lines here. Sorry. We have 3 different lines, but at the end of the day, the message is do not watch this region once a month, but please on every fetus, because the day when you have something suspicious, you are not sure, is it an artifact or is it something normal? So brainstem, the posterior part of the brainstem has an echogenic line. The occipital bone is an echogenic line. And the most important message is the floating choroid plexus in the fluid between the future cisterna magna and the future fourth ventricle. We call that IT because it makes things easier. And this is the pathophysiology. Since 7 weeks, 6 weeks, 7 weeks, when the spine did not close, the cerebrospinal fluid is escaping, and this leads to hindering of an upward position of the brainstem. So the brainstem is shifted posteriorly, and this is why it is squeezed. This is why it is large, and the region between the brainstem and the occipital bone is more or less small. But in the first observation, we said, let's say in our text in discussion, at least in these 4 cases there was no fluid, but we know in the meantime that some 30% have no fluid, the other one may have, but the fluid is definitely not normal. So this is what we see, and this is here the typical image of it. So as I told you, this is one line, the second line, the third line. You can take another approach, but my message is try to understand what you are looking for, because you will know what's going on. So this is one view. You can go for an axial approach of the brain. You see the hemisphere of the cerebellum, you see the brainstem, and you see here, as I told you before, the IT. What I like also in the IT is because it's such a large shaped structure, even if you are not in the true mid-sagittal view, you will always see something. You need to watch this echogenic, which is part which is the choroid plexus of the fourth ventricle. And by 3D ultrasound, you can do here, you can cut in this midbrain, and you see here the choroid plexus, the cisterna magna, and the intracranial translucency. So this was one of the, let's say, striking papers I read before I start. There are 2 things I did. First of all, I went into embryology. I was understanding how much can I see of these images. And this is here the developing cerebellum with the vermis, and this is the choroid plexus. And this is in an article on spina bifida development and the different theories of McClone and co-workers. And this is in mouse embryo. And they were watching the brainstem, how much of the brainstem is going down into the foramen. And this is the normal, and this is the Chiari-2 malformation. You see here that they were showing that part of the brainstem is going downward. But for me, it was interesting to see how thickened the brainstem was, how empty the posterior fossa was. And you see here the plexus, everything is squeezed. And they said, this is something we should see. In the first approach, honestly, we had 5, 6 different curves, brainstem, and all these different things. But Kipros said, no. The first message should be so simple, because if you put 20 curves, people will not take an uptake. We call it simply intracranial translucency. You have one measurement of the fourth ventricle, and later on we can add on other things. So this was the first approach, and this is the typical schemes and the corresponding images you have seen here. Here there are a lot of fluid, and here you see the thickened posterior part with almost no fluid or reduced, and you see the choroid plexus is not floating anymore, it's stuck between the brainstem and the occipital bone. You see here, this is one of the cases. Okay. Another approach was then to say, okay, now there are some suspicious cases. In order to get more close to the diagnosis, if you have any suspicion, you can check that the brainstem in general is always smaller in its thickness in comparison to the distance to the occipital bone. So if you make a relationship of the brainstem to the distance, this should be always smaller than 1, which is the case under normal. If you have spina bifida, this part is going to be larger and the distance is smaller, and it's increased in general more than 1 or more than 0.75. And many colleagues and friends send me images, volume, and say, yes, great, and look at the case, or I missed this case, I could have seen it before, and you see here from different parts of the world. And this is here also volume rendered. And you see here this at 14 weeks, I told you, we may see first this banana sign. So if you doubt, in this case, either you look for the spine. If you don't see the spine, go for 14, 15 weeks and scan again, and you see, well, it's normal or not normal. This is here a case from India. In India, it is very common because you have young population, some with undernutrition plus some vegetarian. So this is in a younger population more common than Down syndrome, and this is why nuchal translucence is becoming more screening for spina bifida than this part. So in some cases, people were not upset, but say, oh, surprise, look, I measured it, but I measured the IT, it was normal, and it was spina bifida. But if you see where the dots are, this here is almost occipital bone. This plexus is not floating here, and this is thickened. So the same here, you see, we have some fluid, but the shape is not normal. Where is the other fluid? We have 2 fluid regions which should be seen. So some people tell me, you know, the cisterna magna is better because if you don't see it, but the cisterna magna may be also delayed in its opening. So this is, as an isolated sign, not working. So for me, it's more important to know what you are looking for because you see it. If you want one measurement functioning always, it will be the brainstem to the distance ratio. But if you place the dot correctly, you know when you are placing the dots what you are looking for. This is why, because some fetuses had some fluid, we said, okay, let us quantify this. You know, from Galileo and Nicolaides, instead of saying my impression is, we make numbers, and the numbers say that I measure the area here, I measure the area there, and I produce reference values of the complete fluid in the posterior fossa in first trimester, and I compare with cases with open spina bifida where we have one compartment seen, and if you compare the value, you see that all cases had less than 5 square millimeter or even less than 10. So if you see, oh, I have an impression the fluid is less, you measure the area and you see that it has a good cutoff. So in cases where you still have fluid, this fluid quantity is definitely low. And there is, to my knowledge, only one case of a false negative. It means having a normal posterior fossa and developing into second trimester spina bifida with all the signs. So this can be, we will never reach some 100%, but let's say more than 90% and more than you have did before. What are the other approaches to suspect spina bifida? Now, of course, when you have a new sign, many people try other way to do. So this was an approach done by Matthias Scheier from Austria, saying I can see the whole changes in the axial view. Okay, this is a good approach, but you are asking people to turn the transducer to get a new view, which is not so obvious. Because we have the fetus with open spina bifida have less fluid in the brain, the angle, the FMF angle is smaller, published by Lachman and Nicolaides. Because we have less fluid, if you measure the fluid in the aqueduct of Sylvius, it is less. In the third ventricle or lateral ventricles, it is also less. So you can see this. This is typical image, could be occasionally the so-called dry brain. You look at the brain, see where is the whole ventricle system here, because it's already collapsed. And we published also an observation because let's say we have less fluid in the brain, and because we know from the first papers in the 80s, Nicolaides and Nick Wald and other, that the BPD is smaller. At that time, it was very important. The BPD was crucial in the 80s. And once Kypros detected the lemon and banana sign, people abandoned the BPD. The BPD was very important because AFP was related to BPD. If BPD is smaller the AFP value may be giving a wrong value. So this was a discussion in the 80s in the correspondence in articles. So, but we don't forget that 70% of fetuses with second trimester spina, they have a small head, and this is sometimes the hint for first referral, and you see the other. So, and we said, okay, we measure the BPD posteriorly without knowing, before knowing the diagnosis, and we found that this BPD was small. This was confirmed by Asma in her paper in 2013, and by Jean-Pierre Bernard with Yves when they compared with the AFP, as you heard yesterday from John Hyatt in their talks. Because BPD may be a part, because the whole fetus is small, Emmanuel Simon and Georges Haddad compared this with the abdominal diameter, which is not changing in spina bifida, and they saw that this relationship, if it's smaller than 1, can be a hint for spina bifida. So you have now more signs, which are the simple sign of measurements, and another sign known since the beginning of the 2000 by the French group by Jean-Pierre Bernard at that time. With, I forgot her name, Odilon or something, and then they said that if you look at the posterior fossa here, you see that there are the parallel course of the thalami and the cerebral peduncles. But these people from Australia, Finn and Co. and Mayer, what they tried to do, they said we compare the distance of the aqueduct of Sylvius to the occipital bone, because we do on all patients a kind of transvaginal scan and we detect all cases. So it's also an approach. I will show you some anatomy of the posterior fossa if you are scanning transvaginally, because this is really very important. So if you look at the brain in this view lower, slightly lower than the choroid plexus, what you see here are the diencephalon with both thalami and third ventricle. We see the cerebral peduncles with the aqueduct of Sylvius, but you see also a kind of distance between the cerebral peduncles and the occipital bone. The shape of this is like this angle. In case of a spina bifida, because you have posterior shifting, you have the choroid the cerebral peduncle pushed posteriorly. In general, the aqueduct of Sylvius is collapsed, and you see the parallel course. I show you now a video clip of this. We have enough fluid in the brain. This is trisomy 18 fetus, and you see here how this is collapsing, and you see here even touching the occipital bone. So if you are scanning transvaginally, this is probably easy sign instead of waiting until the fetus turns. But if you are scanning on a routine for a nuchal, the nuchal is better to look at the IT and the brainstem. Here in doubtful cases, you can render with 3D the brainstem, enough fluid in the occipital, in the IT and the cisterna magna. And you see here in case of spina bifida, the sign I showed before, the thickened brainstem, the absence of a lot of fluid here, and if you have some fluid, it is very reduced. And you can use also other planes, like here cutting in this plane and getting no fluid posterior part, a thickened brainstem, and the same sign I showed before. So if you know what you are looking for, you have several parts to confirm, but in general, it's easier to go for the spine and check it intensively. So in Berlin, and I'm happy that I was not happy, but I was not the one doing this study because I was participating. It was done from the university. They asked 20 specialists, very good specialists, to put all data in a mask. That means on every patient doing first semester scan, we're measuring brainstem and so on, and put in the mask. And we export all this. And after 16,000 fetuses, 11 cases were detected all, but let's say 3 or 4 were suspected at 13 weeks. But let's say once you see the first time something abnormal, you are not sure and you don't see the spine, you ask the lady to come back, and at 16 weeks it's what confirmed. So it works in the hand of expert, but it's nothing for, let's say, for everyone, oh, I see it's abnormal, because the conditions are so rare. In order to be depressed, I had last week a meeting. I met Bernard Benoit, and I told him, oh, I'm going now to London. What are you doing there? I'm speaking on spina bifida. Oh, I'll give you 2 clips. You can show them if you want. I have to show them because he killed me with these one. 30 millimeter fetus embryo before 10 weeks gestation on a twin gestation. And he said, look at this part here. They said, how did you look to the spine? He said, this is twin pregnancy, and one was smaller, but he found that this one had almost no fluid in the brain. And when she come back, he said, I will check it. And he rendered this image. And you see here, it works. I didn't have time to look at the different planes in the head, but he said the first hint was that it was less fluid in the brain, and the case is now very young, and he said a week later the baby had died, so he assumed it kind of triploidy so early. So in future, it's feasible to go earlier, but we need to understand how is the brain inside working, the ventricular system, and we need 3D and understanding embryology. So to finish this part of open spina bifida, ideally, some will say, I see direct to look at the spine, but you can look at the IT, or you can look at the thickened brainstem, or the relationship of the brainstem to the IT. You can look at the angle in general. They have a flat face, but this is something you see once you have seen the posterior fossa abnormality. If you go transvaginally, you will see the parallelism of the cerebral peduncles with the thalamus and the fourth ventricle stuck to the occipital bone. You can see the dry brain in some cases. You can see the small BPD, and if you want to measure some fluid remaining, you can see the small CSF, and you can add, of course, other signs. But let's say, honestly, I don't care which part you are taking, but what I like in this approach is that now spina bifida belongs to the first trimester. We cannot say, oh, we cannot see it, we have to wait until AFP and so on. If you want, you can do this, and the same we'll show you in the afternoon for the large cleft region. Now, this part is more tricky. Should I continue now? Or you want the break? No, okay. No break, okay. Okay, so last part is on the posterior brain. So this is something very challenging, and it's not the last version I'm going to speak about today, because we are still learning. But I know that Gustavo has his own opinion on, and really I was, let's say, very happy to listen what Gianluigi Pilou wanted to say in 45 minutes on this region, and unfortunately he couldn't come, so I have to cover some of the things I know about and my preliminary experience. So I could call a paper or a chapter like this, the increased fluid in the posterior fossa between transient finding and Dandy Walker, because this is actually the message I will give you at the end. Many of the things we will not know, we will have to wait. So there were a few papers, and this is the first paper published by Lachman with Elena Sinkovskaya and my friend Alfred Abu Hamad on 4 cases where they said instead of having a compressed posterior fossa and a large brainstem, they found that the brainstem is thin and the fossa is enlarged, and the relationship is inverse. It's not higher than 1, but lower than 0.5. And they said in these 4 cases, they waited until second trimester, and they saw that there was no cerebellar vermis, so it is typical hint. But the problem is, how safe can you say this in early gestation? We don't know. But if you see this, you should do a control rather in between, rather than waiting for second trimester. So this is the first message. Another paper was published by, there are 2 papers actually on this condition by Volpe and Gianluigi. So in this case, they did the similar approach, 17 cases where the distance was enlarged, and they said there is no septation in the future fourth ventricle. You know what is this septation? The floating choroid plexus. So if you don't see the floating choroid plexus in this fluid, this can be a suspicion of something abnormal. So you control later on, and this is here. They found, and as you see in this case, it can be sign of cystic malformation, Dandy Walker, or chromosomal aberration. So now, if you have to understand this, at the end of the day, the message, and this is the most important slide you will have to take with, is what would I do with this patient? I'll show you the other one is that this is my neighbor. And you see here, I see no plexus choroid because it's here. If people tell me, oh, you know, no cisterna magna is seen, it is a sign of spina bifida. You don't see any cisterna. You see some, but it's collapsed. So, and it's kind of physiologic persistent of the Blake spots probably, but is it normal? Is it abnormal? I don't know. But this is something we'll see often because you are trying on a physiologic development to predict something. And this is really very, very, very dangerous and very difficult to do. So let's go back for the fourth ventricle development. You see here the fourth ventricle. We see at 15, 17 weeks how Gustavo was showing us. What you see here is the normal communication between the fourth ventricle and the cisterna magna. And this is the Blake spots developing. And you see here the vermis later on with the fourth ventricle and the lower part of the inferior part of the worm is touching the pons, and you see the cisterna magna with the Blake's pouch here up there. This is Joseph Blake. He presented 1990 in the New York Academy of Medicine his talk, and it was published 1900, and he described what is known under the Blake's pouch. This is the end of the ventricular system. This is the chorial plexus, and you see this is well, let's say kind of what is now called the pouch. He described it first, and if you know the embryology and the development, you understand what we are speaking about. So I'll show you 2 or 3 images. Little bit difficult to understand, but this should be, if we want, another long talk, but give me 1 or 2 years research and I can come with more ideas. So this here is going to be the pons, and this is here the region. We are around 9 weeks gestation, let's say, or 7-week embryology. So what we see here is the developing cerebellum. This is the chorial plexus, and AMA and PMA are the area membranacea anterior, area membranacea posterior. With the development, the chorial plexus will go into the region of the cerebellum, and we have a bulging of the posterior membranous area. This is the theory until now, and this is the vermis of the cerebellum, and we have here a Blake's pouch, which is bulging, and at the stage, the foramen of Magendie in the middle, or the bilateral foramina Luschke will open, and there is a communication between the ventricular fluid and the subarachnoid space. So this is the normal physiology. Now there are some conditions where this Blake's pouch will persist, and I'm not sure that all cases will be here, because some cases will be also here. This is something which we do not know yet. Now, what is the end of the story? Where are we going to? We are now at 22 weeks gestation, and we have several conditions where we see some more fluid, and these are this one. It can be a normal condition. It can be a normal vermis and lot of fluid, the so-called megacisterna magna. It can be a normal vermis, a lot of fluid, but still a communication between the fourth ventricle and the Blake's and the fluid here, and this is what we call the Blake's persistence of the Blake's pouch, because probably there is no opening or delayed opening of the foramen. Or we have large fluid with half of the vermis, with a normal tentorium, which is the vermis hypoplasia, or we have a true dandy walker with a partial or complete agenesis of the vermis, a large cisterna, and an upward rotation of the falx. So now, do we dare in early gestation, where we don't see yet the vermis, it's not yet developed, to predict which one is going to be there? I'm afraid no, and this is what Gustavo asked me to say. We cannot predict that which condition will be present. But I feel that in some conditions, we will see that this has an obviously severe finding, but will not tell the parents at this stage, I'm sure it is this one. So any finding we'll see today, please have a control at 18 weeks or 17 weeks, because there are some things you can see, and I will show you some cases. So this is the message I want to give you. If we find a dilated IT, at the end of the day, we'll have one of these conditions. It can be transient, it can be a dilated cisterna magna, it can be a true Blake's pouch with a normal vermis upward rotated, or it can be vermis hypoplasia dandy walker. But even if you have one of these conditions, in general, you have to check for chromosomal anomalies, because we know that even second trimester trisomy 18, even 21, they have a megacisterna magna. In triploidy, we have seen also such cases, and in genetic syndrome, it can be dandy walker, it can be Walker-Warburg, it appears like this. Then you look at for the eyes to check for cataract in early gestation. It can be Joubert-related disorders as a large group of ciliopathies, and it can be also Meckel-Gruber, where the kidneys may also be apparent as large in early gestation. I will not show you all the cases I have, because it should have been a small part of the talk, but I'll tell you, this is the main message. Don't say, oh, the ratio is 0.45, it's enlarged, oh, it could be dandy walker. Think about it is more, and check for more. This is one of my best cases, because I love it. I love it so much. Because, sorry? Yeah, because sometimes, you know, there are key images, and this is like Kipros when he took the book of, or the article of Langdon down. He read it several times, and he came back with nasal bone, with other signs. So if you look at this picture, I used to tell you, look at carefully. Is it not nice? 2007. Until 95 to 98, I was saying, oh my God, there is an omphalocele, a typical sign of trisomy 18. So mid-90s to 2000, I say, oh, it has a thick nuchal translucency plus omphalocele. It is a trisomy 18. 2001, 2002, Cicero published, I look at, oh, we have no nasal bone. It is a typical sign of aneuploidy. 2009 or 2012, I said, oh, we have a dilated posterior fossa, and this is typical for trisomy 18. 2015, I said, oh, there is a maxillary gap. It has a cleft. So in one picture, we have 6 signs.
Now 2016, please take this picture, enlarge the brain, and you will see that the cortex, the parenchyma of the brain is absolutely normal, irregular, and have polymicrogyria.
Okay. The Gustavo side. So, but you see that you see only things you are expected to see. So you see here the gap, and you see here this one. This one I said, okay, this is so abnormal. So trisomy 18 may have dilated posterior fossa. And you see if you have some hydrops, I will not focus on, do I see the vermis? I know that this is more often found in trisomy 18 than trisomy 21. We have occasionally one case, but in general, let's say 20 to 30% of trisomy 18 may have dilated fossa, a thickened nuchal, and so on. So chromosomal aberrations is the first thing you look for, and you don't need to wait. You go for invasive procedure. But you see here what is happening in this region, and you see how this is the choroid plexus floating because the foramen magendi open. And this is a lady at 11 weeks, is it 12 or the? Anyway, 12 weeks, where you have a dilated part. And if you know that this was 11 weeks plus 4, a previous history of 2 cases of Dandy Walker, one of them having had a cardiac defect. And you see that there is a cardiac defect, and you see this one, you say, I'm sorry, but I will not wait because we have an abnormal heart, we do CVS, but at that time, 2011, we didn't have the whole sequencing of all these diseases. So this was a recurrent case. She come back, you see it's January 11, she come back June, and this is normal finding. That means in some cases of recurrence, it's worth to look at the posterior fossa, because if you see this, I say for me, it's unlikely that we'll have some severe posterior fossa abnormality because they are related also to a lot of fluid. Likely. I will not say, I'm not sure, because we need some long follow-up observation on many of these cases. So part 1. This here is what Gustavo wants me to tell you, and this is what I do. Lot of fluid in the posterior fossa. I don't see anything else. 13 weeks, control at 15 weeks, where we can do an amniocentesis. All of us doing amnios, we measure the cerebellum to rule out spinal bifida. There was no cerebellum, there was no cerebellum. So this is similar like the cases of Lachman and Sikovskaya, also in all case from the mid-70s. So you can use the dilated one in order to check soon for absence of the vermis and the cerebellum or small cerebellum. So this had also in tricuspid atresia at the heart, but you know, this is a finding confirmed at 15, 16 weeks. This one, a similar case, we saw it 13 weeks, then 14 weeks, until 17 weeks with a large cisterna. This is also likely to be posterior fossa abnormality. And you see the angle is so typical, but I will not delay on. What can we do at 9 weeks plus 4? 9 weeks plus 4, linear probe. This is not a nice view of the fetus, is it? This is a patient I like very much because she had 3 previous cases. They are not consanguineous, but it's autosomal recessive. 3 previous cases of posterior fossa with encephalocele and kidney abnormalities. We checked for Warburg, but she was at other centers before. They checked everything, Bardet-Biedl and Warburg and so on. And so I said, you know, I'm not sure because I will not tell you it's abnormal, but it does not look for me very normal because you see here the brainstem. She came back at 10 plus 6. You see here. And this is 3D where you see this is the gap, the encephalocele. If you want, I can show you the case later on if we have time for case demonstration. But you see here the gap for the encephalocele. This was a Joubert type 14 at the end detected after 4 cases. So it is worth to control an abnormal posterior fossa, but you need either a history or you need a second trimester scan or you need additional abnormalities. But be careful on taking conclusion out of one suspicious or one value of 0 point something. So my conclusion, I hope I showed you that, is the spine and the posterior fossa should be evaluated together, either on 2D alone or if you have some skill to add 3D to it. Transvaginal, always add 3D because this is easier done, unless you are Gustavo and you can how do you call it? Turn the uterus in the correct position. Maximal mode, I abandoned to use in the first semester because it does not add any things. And to check the brain, use tomography and silhouette because you can look at inside the brain. And I thank you very much for your attention.
Thank you very much for this wonderful lecture. Do you have questions for Rabbi?
This was the tie, Yaron. Own experience. Give me your own experience and we can learn of this.
So here there is a comment from Mehta, Dr. Rabbi's comment on transabdominal versus transvaginal for early anomaly scan is practical. Apart from what was said, when would you opt for transvaginal scan?
Thank you. Easily said, if I see on my routine scan any suspicious part or if I have a high-risk patient, I will go for transvaginal. And in earlier gestation. But in the last case I showed you, at 9 weeks, transabdominal probe showed me already the problem. I'm not sure if I went transvaginally, I could have a mid-sagittal view like this one. But then I can use the volume and render it. But let's say for practical approach, if you have a low-risk patient, you scan normally. If you see such enlarged fluid, then you can go transvaginally. If you see suspicious of spina bifida, then you have to go transvaginally to check, to rule out, and to demonstrate the open spina bifida.
Then there is a comment from Professor Volpe in Italy who says that 12-13 weeks, 2 spaces instead of 3 spaces in the posterior fossa is crucial and always pathological. This is a simple sign that it is impressed.
Yeah. Let's say, hi Paolo, if you are listening to us.
Hi.
I showed your paper, but the case I showed you, what's called my neighbor, showed that we had the brainstem and fluid, and because the choreplexus was stuck to the posterior, to the occipital bone, so some delayed opening of the foramen magendi may mimic this image. So I will not, this is nothing, honestly, for a routine, normal gynecologist. This is in hands of specialists, and the specialists will know how to deal with these conditions. I agree with you, but this is something to be controlled without saying it is always abnormal. Because if I tell the patient it's always abnormal, it means I don't matter what's going on. But let's say the main message, the simple sign what I want to give you today is if you see a floating chorial plexus in the fluid there, it is neither a typical sign of open spina bifida nor a typical sign of severe posterior fossa malformation because it is not there. If it's floating, it means likely that the foramen of magendi had opened and we have a normal. So this is in other ways the space region you are describing, Paolo.
There is questions from Alex Eskander.
Thank you, Katia. So you did a scan, you suspected spina bifida on brain signs, the brainstem, the IT, at 12 weeks.
Yes.
So do you counsel the patients with view to termination, or whatever you give her the choice, or is it a definite, or do you wait to see that the lesion of the spine later on?
Okay, let's say in the few cases we saw in our unit, we were able to see the spina bifida.
Well, at that time?
Yeah. After the...
But if you don't?
Wait. The first case. So the first case I detected prospectively. I saw the spina bifida after having seen this one I showed you here with when the baby turned around, and the lady asked, "Can we close it easily because it's like a zipper if it's open, or because it's early is it going to close on its own?" I said no. And she said, "I want a termination." I said, but sorry. If you go to a center and they don't see neither lemon nor banana, they will not terminate. But she went to a good center, and they knew the report. They scanned vaginally until they saw the spina bifida, and she decided not to continue. So in our series, the one in Berlin, one decided to continue, which was a cervical one, and she had a premature birth, and the baby died at let's say 17 weeks, at 27 weeks. My vision for the one trying to do fetal surgery is that they should work on tissue engineering that they can start at 14 weeks, because then you are very early in, let's say, in increasing the position of the posterior fossa. Because,
the question really is, do you wait until you confirm that the spine is abnormal?
Yes.
You wait.
Yes.
Okay, let's say for the other, I see it. I showed you Benoit see it at 9 weeks. Next year I'll see it also at 9 weeks if I have the patient. So, but this is not the issue. The issue is if everyone is doing no way to terminate the pregnancy because they think the posterior fossa is abnormal. Neither because there is no fluid, nor because it's increased fluid. The aim is for the less fluid to check for the spine until you see these signs. If you are not able to do it, you can wait until 15 weeks. You can start with AFP plus lemon banana sign, or for the increased fluid, you wait until 16 weeks to see if you see a vermis or if you see a lot of fluid, if you don't see cerebellum. So, of course, you have to wait. This is the major issue, and also for the heart. But the difference here in the two diseases, again, the difference is for the spina bifida, I can switch and see the spina bifida at 13 weeks. I can see it. And I will scan the lady day and night until I see it, or I rule out what I can. But for the posterior fossa, fluid malformation, I cannot tell them at 12 weeks yet what's going on. This is why I need, for this patient, follow up unless they have a history and we know what is there and we can do CVS and confirm.
There is another question on this. Okay, so the comment was not from Professor Volpe, but I heard him in a meeting yesterday. So that this is a specification regarding the previous. And then there is another one which is asking how is the nuchal translucency in these cases of enlarged posterior fossa?
They are accidentally neighbors, but they have nothing to do with each other. Nothing. Spina bifida and thickened nuchal, they have only to do with each other if it's a triploidy or trisomy 18. But a thickened nuchal translucency may have always a normal posterior fossa and vice versa. So in spina bifida, in the series of Neil Sabir, there were 1 or 2 cases of spina bifida with thickened nuchal. This is why they were overlooked in the past. So,
if I may correct you,
yeah.
I think that she is referring to the enlarged posterior fossa. So
okay.
to the last cases.
Okay. The large posterior fossa, I told you there are several groups. One of these groups is a chromosomal aberrations, and this is likely to be to have both together. So let's say more or less a thickened nuchal translucency with large posterior fossa, I will suspect first trisomy 18 and not trisomy 21. A simple sign. Yeah.
Okay, thank you very much. So we have now a coffee break until 11 o'clock. Thank you.